Good morning, everyone. Good morning to our distinguished colleagues and participants. Welcome to Nala Genetics CollabTalk Series. This is a collaborative webinar focusing on a critical topic in breast cancer treatment. And today's webinar is titled CYP26 Genotyping for Personalized Therapy of Tamoxifen in Indonesian Women with ER-positive breast cancer. My name is Dr. Tami, and I will be your moderator for today's session. Today's session is organized by Nala Genetics, MRCCC Siloam Hospital, Semanggi, and Faculty of Medicine at Majaya to share groundbreaking insights into personalized therapy for ER-positive breast cancer based on genetic profiling. We are honored to have with us today Dr. Samuel Haryono, spesialis bedah konsultan onkologi. He is a leading expert who will present key findings on the role of CYP26 polymorphism in tamoxifen metabolism among Indonesian patients. Good morning, doctor.
Good
So,
morning.
morning. Before we proceed, can we move to the next slide? I'd like to remind all participants to kindly fill out the attendance form here to ensure your participation is recorded. The form will only take 30 seconds to complete. For live attendees, the link has been shared in the Zoom chat box. Please click on the link and submit your details. And for those joining via YouTube or live stream, the attendance link will be available in the video description or comment section. Your cooperation is greatly appreciated. This will help us provide certificates and follow-up materials to the registered participants. Okay, we can move on to the next slide, I believe. So, yeah, here are a few housekeeping notes. This webinar will be scheduled to run until 12 p.m. with a Q&A session will be held after the presentation. Please submit your questions via the Zoom Q&A feature or directly in the chat, the Zoom chat box. We will address them during the discussion. And also a feedback form will be shared later because your input is obviously invaluable to us. So before we get started, I'd like to take a minute to introduce Nala Genetics. We can move to the next slide. Yeah. So I'd like to take a minute to tell everyone here about Nala Genetics, who we are, and why we are so passionate about this research. Our story actually began with one of our founders' family experiencing severe side effects from medication. So that personal experience made us realize that what if we could use genetics to prevent these kinds of reactions? And that questions became our mission to use DNA testing to help people get the right treatments from the start. Today, we are proud to have developed proprietary technology that's being used by doctors and hospitals across Asia and Europe. The study we're presenting today on CYP26 and tamoxifen is exactly the kind of work we care about, using genetic insights to make cancer treatment more personalized and effective for Indonesian patients and Asian patients in general. We're really honored to be working with such great partners on this. MRCCC Siloam Semanggi, Faculty of Medicine at Majaya, Universitas Indonesia. So if anyone wants to learn more about what we do, we'll be happy to chat after the webinar, or you can visit our website to connect more. Okay, with that, let's move on to the next slide. Yeah, we're incredibly proud to have a roster of experts and key opinion leaders in clinical genomics from right across Asia. On the right side of your screen, you'll see our KOLs and collaborators, a powerful network of esteemed professionals who work hand in hand with us, bolstering our research and applications. We're honored to collaborate with this distinguished group of individuals, including Dr. Samuel Haryono. And at the bottom, our institutional partners. These are our top tier institutions like the Genome Institute of Singapore, National Cancer Center Singapore, and National Neuroscience Institute, and among others that are absolutely vital to our research, validation, and ultimately bringing genomic medicine to more people. This powerhouse team, backed by the strong institutional partnerships, truly puts Nala Genetics at the forefront of clinical genomics innovation here in Asia. With that, we shall move on to the next slide. Yeah, these are our several of our hospitals, institutions, and universities partner across Indonesia and Southeast Asia. Without further ado, let's move on to the next slide. Yeah, with that, let me introduce briefly our distinguished speaker for today, Dr. Samuel Haryono. He is a leading surgical oncologist whose expertise bridges clinical practice and cutting-edge research. Dr. Haryono's impressive career spans decades of dedicated work in cancer treatment. After completing his medical degree at Gadjah Mada University, he pursued specialized training in surgical oncology at Universitas Indonesia. But what really sets him apart is his commitment to staying at the forefront of his field. He's enhanced his expertise through advanced training at world-renowned institutions like the Memorial Sloan Kettering in New York and the University Medical Center Groningen in the Netherlands. Dr. Samuel, currently serving as head of the medical committee at MRCCC Siloam Hospital Semanggi, and he brings both deep clinical experience and a strong research background to today's discussion. So we are absolutely incredibly fortunate to have someone like Dr. Samuel share his insights with us today. And without further ado, let me invite Dr. Samuel Haryono to deliver his presentation. Everyone, please give a warm welcome, and to Dr. Haryono, the floor is yours.
Good morning. First, I have to say thank you to Dr. Tami, who has already introduced my background, and also I'd like to express my gratitude to the Nala Genetics, who has continuously support us in doing the research, and also for the Atmajaya University and Universitas Indonesia for bioavailability and bio lab for having conducting the research so far, and it is quite happy today for me to again to present our result and our presentation. And before I start, I'd like to state that to express my condolence, my grief announcement that last night the father of Dr. Asik has just passed away. So we would like to send our condolences for this announcement. So let me start with my topics. It's about CYP26 in the genotyping for the optimizing of tamoxifen therapy in Indonesia for women with ER-positive breast cancer. First, I give some highlights that the ER breast cancer is almost, about 80% of the invasive ductal carcinoma breast cancer. And secondly, that the tumor cell level of ER breast cancer expression, the ER expression, is close linked to the therapeutic effect of the endocrine therapy for the target of the ER, estrogen receptor. And third, I'd like to inform you that hormonal receptor breast cancer is associated with the less aggressive breast cancer, so will be better prognosis. And hormonal therapy with the tamoxifen tamoxifen is quite affordable, cheap. So I'm going to give emphasis on this study that because the better prognosis will be a benefit for the currently endocrine therapy. And tamoxifen is considered to be the first line therapy for the ER breast cancer cases. Well, the first slide. Yeah, this is my, it's been published in the Personalized Medicine this year at in February. Yeah. Next slide. Well, I like to give the background why that, as I mentioned, that this is a very frequent or the most common cases of the breast cancer. As we have got a report in 2018, the Indonesian has the total breast cancer incidence about 58,000, and it was monitored quite well, that we are trying to monitor about the incidence, but then 3 years later it was quite increased until 66,000 2071. Here the tamoxifen as the SERM or selective estrogen receptor modulator is the most firmly established adjuvant endocrine for the women with the breast cancer. And here tamoxifen is actually is a prodrug that needs to be metabolized in the liver by a cytochrome which called P452D6, or as known also as CYPD26 enzyme. So to the end result, the active is endoxifen. So here I show you the chart, the flow of how the tamoxifen was metabolized. However, CYP2DX genes has many variants, many variants which are also non-functional or reduce their function. So there are quite numbers that are being considered. But anyway, here the CYP2DX, with the genetic polymorphism, they also got the individual that we are trying to classify in the phenotype. There's been considered the 4 phenotypes. Before I can tell you further about the phenotypes, but here on the chart, the endoxifen mostly mostly got the CYP2DX from the N-dismethyl tamoxifen, and this is about 100 folds. Yeah, 100 folds. This is the most affinity to the ER, and then it's higher than tamoxifen. So, well, as I mentioned, that the CYP2DX, the metabolites, the metabolizer genes on the genotype, they will be translated into the phenotype into the 4 types. First is the ultra metabolizer, and then secondly is the normal metabolizer. Third is the intermediate, and the last one is the poor. So the CYP2D is as highly, as I mentioned, polymorphic variants. And since we try to get the research on this, we got some data from the Asian women, that it's been revealed that the star variant 10 polymorphism in Asian women for the cancer is the best for the breast cancer receiving tamoxifen. It's associated with the effect of the disease-free survival and the recurrence rate. And yet we don't know yet the Indonesian about the polymorphism, about their distribution in the Indonesian population. So yet not yet conclusive whether the genotype guided for the dose adjustment can improve the patient clinical outcomes in Indonesia. Next. Yeah, here is the dosing adjustment recommendations for the CYP26 phenotype and Clinical Pharmacogenetics Implementation Consortium, CPIC guidelines has given for CYP26 and the tamoxifen therapy for dose adjusting. Here I emphasize on the three things. First, the normal metabolizer, which is about 1.5 to 2 the activity dose, and here they can prevent or can reduce the recurrency, and this dose is classified as the normal. But actually in the Asian we could classify only these other two, which are important, is the intermediate, which is quite high in Asian population and also Indonesian. So I try to classify for the intermediate and the low or the poor metabolizer, which needs to be dose adjusting, or maybe could be altered by the aromatase inhibitor for the substitution to get the similar effect like the normal metabolizer. Slide. I'm trying to give some explanation, some steps of the methodology. Well, first for the recruitment, we recruited about 150 patients for the tamoxifen for the at least eight weeks were prospectively recruited after having the tamoxifen. Then the sample were collected. The sample were collected. So it started with the buccal swab, and here with the oral collect, which by bio red CFX 1696, and using the real-time PCR for the detection system, and also here the peripheral blood, whole blood was also collected. The next step is the genotyping. The CYP26 genotyping was done by the qPCR, the NALA Singapore, and having the haplotype, diplotypes, and the phenotypes were inferred in the NALA clinical decision support. And the next is tamoxifen metabolizer assay. This is collecting the blood and using the pump, volatile absorbable micro sample, and using UPLC, and having working collaboration with the University of Indonesia, which has been, the system has been validated by FDA and EMA guided. So we do the collecting the blood samples. And the last is about how we analyze the survival and the progression. Here, with the FACT-ES questionnaire, we assess the adverse effect for the adjusting dose, and also patient will follow at least 3 years here to know about their, we want to know the overall survival and progression-free survival. Now the result. Udah ya? Belum. The result, yeah, again with the 51 patients were collected to participate this study in our department. Breast Cancer Care Alliance is our division, working together with the clinician and the scientists, with the nurses. We try to collect to do on their protocol, and collected since 2019 to 2021 April. Well, the sequence is starting the numbers and gradually reduced by the dropouts, and they didn't show to the criteria selection. And then after that, having follow the criteria, we can divide into the 3 categories, which are, first is intermediate metabolizer, poor metabolizer, and normal metabolizer, and the number is the 68, and then 2 and 83. So altogether it's 150, and then again with couples of dropouts, until we divide, we try to categorize using the CPIC classification for having the cases which have to get the addition of tamoxifen, or choosing the aromatase inhibitor as a substitution, or the alteration to change to the first we or for them to change to alter to aromatase inhibitor, and the result then were followed. And here are also how we monitor in 2 years about the survival and the progression-free survival and overall survival, and their adverse event slide. The pharmacogenetic testing result, the CYPD26, the star 10, as I have mentioned, is about 30%, yeah, from this population. From the it's quite high, and then this is the haplotype of the 10, but the second one, if you can see on the figure 1, the haplotype frequency in Indonesia, the first one, this is the start 10, seem that it's quite comparable with the pharma KGB of the East Asian population. But the next one is about the 36 star. It's quite different, yeah. ours is quite high. Yeah. So having with the this comparison, we know that in our population, the 36 is quite high. And then having a duplicate metabolizer, and we are seeing here that the phenotype for the 10 and 36 for the normal metabolizer is considered to be the most, yeah, and followed by the next here, as you see in the table. So the intermediate metabolizer is about 30%. It's quite interesting for us to know, comparing with the like in the Europe it's about 3%, and also in Africa it's not as high as our population here. And so if we get further about the testing result, the almost 43% of the ER positive breast cancer patient were intermediate metabolizer. Wow, I think I was also quite surprised when I found that result, that I have to quite fierce monitor that how they are quite high. So we offer with the patient to share, because this is the first time in our population that tamoxifen, even it's a common use, but we feel quite surprised. I mean that we are quite scary that this cheap, I mean the tamoxifen is quite affordable. Afraid they could not would not well treat patient for the common cases of the ER positive cases. So we try to get further, how about the other factors, confounding factors. But before that, because it's something about the genetic, so we also focus on the ethnicity. Here, the ethnicity we got, which are quite prominent, is the Chinese, Indonesian, and the Japanese. So the Chinese Indonesian refused to be the most, yeah, for the intermediate metabolizer, almost 60%. It's quite similar with the Singapore study. The Chinese ethnics is quite high, is higher, and here the Japanese is mostly their normal metabolizer. You can see here the distribution and the distribution of the phenotype here in the ethnicity, and then on the left is how the frequency among the Indonesian breast cancer patient. So there are quite significant to see here that the intermediate metabolizer is higher. Next slide. Now I'm going to show you about the difference in endosiphen level between the normal metabolizer and the intermediate metabolizer groups at baseline. This is actually statistically significant. Yeah, you can see on the figure 4. Yeah, that the distribution of the endoxifen levels of for the normal compared to the compared to the intermediates. Yeah. And then on the figure 5, so the endoxifen levels before and after the dose adjustment for the intermediate metabolizer, and the result was no statistically significant difference in the endoxifen level. So you can see on the table 2 that here even on the other enzyme which are shown here, on the yellow yellow on the right, that it's not significantly different. So we are going to the next slide. That's quite similar, that we can adjust, meaning that we can adjust the intermediate with having added after dose adjustment the level the endoxifen level is quite similar, no significant difference. Slide. Now about the function assessment of the cancer therapy of the FRCTAS. Here it's quite difficult for us to get some information. How can we, especially that we got this about the two things, yeah, there are two items. First is about the weight gain, and the one with the lost interest of sex. I think we try that how their impact on the psychological effect. We could report it. It's quite meaningful. So I'm thinking that we'll get further comparison with others, that how this one could be something that could effect on the treatment. But actually the result has no significant statistically different. Next. Now, the last one is about the survival. The statistically significant association were indeed observed here between the disease stage. Yeah? Actually, these are we recruited different stage of the breast cancer. So here that the figure on the 6, this is about the number of disease participant for the stage. So here the most disease participant were stage 3 at the recruitment, and while the figure 7 we could see the progression. So we see that here the stage 2 and 3, yeah, mainly 2 and 3, the progression is high, is quite fast. It's higher comparing with the other stage. Well, I think this is how that we will know that so many confounding factors here, but tamoxifen as for preventing the progression, I think we will see why that is on the stage 3 and 2 is the most meaningful for the survival. Let's see the next slide. So the overall survival, well, the overall survival, the hazard ratio for the year 3 is 2.0, and here you could see that between taking the tamoxifen 40 milligrams and comparing with the normal metabolizer, even this is not significant with the p-value 0.35. Next. And also the progression-free survival, and also here also it's not significant different. Even we can see the Kaplan-Meier showing about these two patient with the tamoxifen 40 milligram and 20 milligram daily. Next. So my conclusion that there is a potential high proportion of intermediate metabolizer among the Indonesian population, as shown with our population. And then the second, the dose adjustment of tamoxifen to 40 milligrams daily successfully increase endoxifen levels. And in the intermediate metabolizer to a similar level as the normal metabolizer at baseline. And also the study identified no significant adverse event among the participants, and the study identified no significant adverse event and has the potential to improve survival. And the last, implementing pharmacogenomic testing of CYP26 on the ER positive breast cancer women who are about to undergo tamoxifen therapy would be beneficial to increase the likelihood of achieving expected endoxifen level, thus better treatment efficacy. And with the genetic, with the pharmacogenomic, and also with measuring the level of the metabolites, we have the first in Indonesia that have proven that the distribution of the CYP26 could be detected quite important, meaning that it's quite high, 40% incidence is meaningful. It would be fruitful, and hopefully that we can do further study to know that how can we get any better treatment for this endocrine therapy. Thank you.
Thank you very much, Dr. Samuel, for the highly informative presentation. Now, I think we've shared a lot about our research. Now we are keen to hear your thoughts from the audience. So we'd like to open the floor for questions. If any of the attendee or participants have any question, you are welcome to raise hands. If you wish to ask a question live, or you may type your question in the Zoom chat using the format. Meanwhile, we have received several questions from the audience via the direct message. Dr. Samuel?
Yeah.
Yeah. So questions, we have three questions. Number one, what are the practical recommendations for CYP26 genotyping in Indonesia, given the high genetic variability?
Well, the practical recommendation, I think, is easy because we know quite well after having that study that actually we know now that the distribution of this CYP2DX gene, we have to do the genotyping to get easily patient to get more to get better treatment by having the swab. I mean, for a test, CYP2DX metabolizer test. Then after adjusting after having for, let's say, taking the tamoxifen for 3 months or more than 2 months, then the recommendation we recommend those who are ER positive, and especially the ER higher percentage. It is recommended, and also it is strongly recommended to test their metabolizer, their genotype, to get further better adjusting dose. Is it being added for 40 milligrams for the intermediate or poor metabolizer, or could be altered into the aromatase inhibitor? Yeah, this is the practical recommendation for clinical daily practice for patient.
Okay, thank you, Dr. Samuel, for your straightforward answer. Now, the follow-up question is, are there alternative therapies for patients with poor tamoxifen metabolism due to CYP26 polymorphisms?
Well, I try to learn, I mean, the outcome of the study, that this enzyme is so important, and we have also a proof, yeah, comparing with measuring the concentration of the metabolite in the blood, and it's quite comparable. I mean that it could be recommended. So I'm still keep on the tamoxifen as the primary, or as the first line. But if something that could be could have some reason to alter, is that yeah, as I mentioned, is we move to the aromatase inhibitor with the overall functions suppression. But to the alteration, I think we try to give some advices, because for premenopausal, I think tamoxifen is still quite strong, as we know about how the strength of the hormonal treatment with the tamoxifen. So alter that for the premenopausal, I think it could be for those who are got some, let's say, adverse event, which are not so much. I mean, it's quite different in our population, the adverse event. Let me see that we have 3 adverse events mostly mentioned in the tamoxifen. First, about the hot spot, hot flush. Well, this is, yeah, quite often hot flush. We could not, we don't pay complain so much, or not pay attention on the side effect. I think they don't complain so much. And secondly, about the thrombophlebitis, I think even now I haven't found any. And the third one, it's so small number of having the endometrium malignancy. So I recommend that you may choose that one, but with another side effect, with another adverse event, like the pain in the joints, and some they have and more expensive. So I'm still trying to keep on the tamoxifen as the first choice.
I see. Thank you very much, Dr. Samuel, for sharing your invaluable expertise on this matter. We have another questions in the chat box.
Yeah.
Number one, the question is about the cost of the pharmacogenetics cost and the time it takes to get the results. So for Dr. DT, if you're interested to learn more about our pharmacogenomic services, our team will reach out to you with detailed price list for the test. And as for the TAT, CYP26 is being included in our 2 of our pharmacogenomic services. The number one is the most basic panel, where we only test for 4 pharmacogenes. That is, the product is called RX Ready, and the TAT is 6 to 10 days. Whereas for the more complete pharmacogenomics panel, we have the most comprehensive panel is called the RX Max. and the TAT is around 2 to 4 weeks. So yeah, the price will be variable according to your region. So definitely we will be happy to chat more on this, and our team will reach out to you, doctor. Thank you very much for the questions. And the next question is from Dr. Yanita. She is a clinical pharmacologist from Mitra Keluarga Hospital. The question is, the NCCN guideline from 2025 did not recommend pharmacogenomic testing CYP26 of tamoxifen. Meanwhile, the CPIC guideline recommended tests. So, Dr. Samuel, would you kindly share your thoughts or opinion on this matter about this, the difference between two guidelines?
Okay. Well, as I mentioned, the incidents, back to the incidents, we are now having a study of the genomic test, or genetic test. I think for the era of precision therapy, I think it will be quite important to guide our patient individually. But the incidence in the Europe is low, and even they have the ultra high, but we don't have that. But mostly our population is the intermediate and normal. But the intermediate, yeah, the poor is we could forget it, and also the poor metabolizer and intermediate metabolizer, those patients we make in a one group because statistically they are not so different only our study. But here 40% is a big numbers. So why don't we have to wait the recommendation from the West? So we have our own study, and we trust with our how the patient daily we try to follow. That's why when we do on the survival, it's not yet significant statistically. It's about some numbers that I mean the study the patient samples. Maybe if we do further, it's like now we get further study for the not only 3 years, we get later, and we try to control our confounding factors, and we will report to the pharmacy, to the Fornas, yeah, formulation national, to consider to have a to add to invite others to do this study, especially from BBGS. These are big numbers. How we have to move. The cost, it is very costly to move into aromatase inhibitor. So I don't mind if there is still not yet being recommended in the NCCN or even the ASCO or ESMO. I think we have to try to do something that we need to our own population. And I believe that our study, even we initiated the first, but this study is it's quite costly because we have to start. Let's see, the University of Indonesia, they bought this expensive equipment to measure that this is the right to compare about the level of the endoxifen, and it's quite significantly proven that it's quite the level it's between the intermediate normal metabolizer after the intermediate metabolizer been dose adjusting. I think I still believe that I don't I have to invite to join with others, invite others to do further study. Thank you.
Thank you very much, Dr. Samuel, for the very enlightening answers. So to Dr. Yanita, I hope Dr. Samuel's answer is pretty can provide some valuable insights to your practice. We welcome if you have any follow-up questions, Doctor. Feel free to raise your hand, or you can also drop the follow-up questions in the chat box. We do have, in the meantime, we do have one more questions. It is about the accessibility. So, Dr. Samuel, in your expert opinion, what do you think are the barriers in the clinical adoption or implementing pharmacogenomic testing in clinical practice, especially in Indonesia? And how can we move? How can we move forward from those barriers?
Yes, yes. Yeah, it's a good questions, and I like to share with my experience with my group. When we started our study, mostly patients are quite scary because anything with genetic tests, because we call that also, this is a genomic, it's a test of genetic test. They are afraid. We have a study also doing collaboration with NALA about the genetic tests. They are quite intimidating, so difficult. They will answer, give the reason to delay until discuss with the family. I'm trying to convince them because I'm in the let's say in a lucky position. Cases of the ER positive patients, it's a lot, and also tamoxifen is I call is a kacang goreng. It means it's a sellable. It's a lot. If there's something wrong, there's no let's say the tamoxifens out of the market, there'll be a great issue. So I'm trying to get that strategy to convince them. If you follow that and you get that for 5 years, that's a long time of medication. So do you believe? Are you okay if the concentration, the therapeutic effect is not correct? It's not yet being detected, being studied. So this one is not just for you; it's for others, for us. So that's one started. Some volunteers they understand that, and also the NALA genetics started with I think with a good. The approach is quite understandable for the others, and they started to follow that, and the result, because about almost 40%, so they share to others. We have to add the just to adjusting until 40. How will it come? I also quite scary to follow that. It's double, and the problem is I'm waiting for a complication for, let's say, if there is a meteorology, it could mean that, wow, there will be a complication as the worst adverse event, or might be that they doesn't work, still got cycle. Even the purpose of the sum is to make the patient amenorrhea, but this is we are following that. But gradually we know that by having our experience, our action with the patient, yeah, from small numbers they could share, then we could know by ourselves that this is very important drug. So then the second steps that we try to follow about our study is how the survival, how the progression-free survival, but it needs more further study to get there their let's say for the cohort with the more strict criteria to know about the effect for this dose adjusting. But I think the limitation is from the start. But now I have to be quite frankly, I have to knock to the door of the government, because while we are doing for the efficiency in every single expense, why not we still keep the tamoxifen as our first, the primary, the first line to have that. And this one, I'm thinking that I feel there's no more limitation. That I'm more and more colleagues, they are share with me. They are waiting for us to share with that. But we have to be open for this very important, very useful, and very more beneficial, especially in the cost benefit for the tamoxifen. I think it means a lot. You can compare about the price. So I'm very positive, and I try to convince other that I think the limitation and the barrier will be solved easily. And it is very, even the high cost drug could be easily implemented when it's important. This is very important. And this is a case of most, the incident, the high incident case, and the best is the treatment in the endocrine pathway, and the tamoxifen is the first line. And I hope that having this genetic test could also make others believe that having more on the gene is not intimidating. It is it's like like obligatory. I feel like obligatory, because I want to keep the patient in a good survival. So the hormonal is keeping, not easily move to a higher level, but still keep that, because I think if we do that the right dose, I think hopefully the study will reveal, will turn out to be quite proven that we are doing the right way. Thank you.
Thank you very much once again, Dr. Samuel. Thank you for such a powerful message. I think your message is loud and clear. And thank you again for sharing your invaluable insights with us today. So everyone, let's give another round of applause to Dr. Samuel. I think we have no further questions from the audience. To quickly summarize today's key takeaways, number one, CYP26 polymorphism significantly influenced tamoxifen efficacy. Number two, pharmacogenomics is essential for personalized breast cancer therapy, particularly in ER positive cases. And then further research and collaboration are needed to integrate genetic testing into clinical practice, especially in Indonesia. Thank you everyone once again for joining us in today's session. Before we wrap up, we kindly ask all participants to complete the feedback form. You can scan the QR code that is being displayed on the screen, or we have also shared the link in the chat. It will only take 2 minutes to complete this form, and this will provide invaluable insights to our team also. Once again, on behalf of the organizing team, we extend our deepest gratitude to Dr. Samuel, to the SGH initiatives, to MRCCC Siloam Semanggi, Faculty of Medicine at Atmajaya, Universitas Indonesia, all our partners for their invaluable partnership in making today's event possible, and also to all participants for making this webinar a success. Thank you for your trust, for your support and dedication. We definitely look forward to many more opportunities to collaborate and drive meaningful impact in cancer care and genomic medicine. So definitely stay tuned for future CollabTalk session. Before we finish, before we officially wrap up, let's capture this moment together. We'll be taking a quick group photo. So we kindly ask everyone to turn on your cameras and give us your best smiles. In the count of three, we will take a group photos. 1, 2, 3. Maybe 2 times more, I think. Okay, let's take another round. Yeah, I think that's enough.
Yeah, thank you.
Thank you very much, everybody, for coming to today's session. Wishing you all a productive day ahead. Thank you, and see you in our next collab talk session. Thank you, everyone.
Thank you.
Thank you, doctors.
Dr. Sam,
Hey, sorry.
are you